Good morning, everybody. I'm hosting from Townsville, as Sarah said, and I'm on Wulgurukaba Bindal country. It's my pleasure to introduce Dr. Tess Hall today to give this presentation. Tess is a postdoctoral fellow at the Centre for Research Excellence in Childhood Adversity and Mental Health at Murdoch Children's Research Institute and the Centre for Mental Health, Melbourne School of Population and Global Health. Tess has extensive experience in mental health service, policy and program development and evaluation in both low and middle income and high income country settings, including Timor-Leste, Colombia, Peru, Sri Lanka, the United Kingdom and Australia. So thanks very much for giving this presentation, Tess, which was awarded one of our prizes at last year's end of year event. So I will put off my screen and voice now. If anybody has any questions throughout, please just type them into the chat button and I'll ask Tess at the end. If that's okay, Tess, you can stick around for a little bit with answers. And just remember, as Sarah said, we are having a few technical difficulties, so the progression of the slides is a little bit slow.
Thanks very much, Tilly and Sarah. Bon dia, Itabotsura. I am Tess Hall. I will turn my video off very shortly because unfortunately I love images and that's what's slowing our internet connection down. But don't be put off. I hope the images themselves are going to keep you here. So thank you for coming today. So I'm going to present on my PhD research, Are People-Centered Mental Health Services Acceptable and Feasible in Timor-Leste? But really wanting to recognise that obviously the Health Services Research Australia and New Zealand is a relatively high income country focused organisation. So thank you particularly for coming here for this strange and quite unique and nuanced global health presentation. So a little bit of background. I've changed the slide now and hopefully you'll get a beautiful picture of Baucau, which is in rural East Timor, and the rice paddies there in rainy season. Why was I interested in mental health in low and middle income countries? So mental health is defined by the World Health Organization as not merely the absence of disease, but as a state of well-being in which every individual realizes their own potential and can contribute to their own community. So recognizing both the kind of positive and also negative aspects of mental health. Through the Global Burden of Disease study, mental and substance use disorders are now recognized as one of the leading causes of disability worldwide, accounting for 7% of total disability adjusted life years. And the discipline of global mental health, which is where my PhD research is situated, has evolved to focus on strengthening mental health systems in low and middle income countries, where many people and families affected by mental illness don't have access to supports. So, oh dear. Sorry, don't know where that's. So people-centered mental health care is a recent influential paradigm in global mental health and broader global health efforts. And the WHO, World Health Organization, defined people-centered healthcare as an approach to care that consciously adopts the perspectives of individuals, families, and communities, seeing them as both participants and beneficiaries of trusted health systems that are responding to their needs and preferences. But this centering of healthcare around people is not a new idea, and people-centered mental health care has evolved from earlier concepts of patient and person-centered care, which is really important for us to understand why it might not be applicable in low and middle income countries. So patient-centered care emerged to remedy the limitations of a purely biomedical approach to mental health care. So aiming to convert this hierarchical relationship between doctor and patient into one in which clinical decisions are guided by the needs and preferences of people. Subsequent to that though, there's been a focus on really shifting from a patient-centered to person-centered care, which is recognizing that a person is a whole person and not just their physical disease. Also aiming to individualize care, seeing the service user as an expert of their own needs, and focusing on the broader social recovery of a person rather than just curing symptoms or illness. But there's a wealth of research over many decades that's shown that there are key health service, resource and training barriers to achieving person-centered care, which has led to a focus on people-centered care, taking a health services or systems approach in which a person is understood in the context of their families, communities, the health service, as well as the broader social determinants of health. In recent times, there's been a proliferation of people-centeredness popping up in sustainable development, in development programming, in human rights-based approaches to disability, such as the United Nations Convention on the Rights of Persons with Disability, and then just broadly global health, health service, health system strengthening work. And just as my PhD started in 2016, the World Health Organization released their first framework on integrated people-centered health services. So this framework didn't provide a particular model of people-centered healthcare, but instead offered 5 strategies for achieving people-centered services. So the first is to empower and engage people and communities. So providing them with the opportunity, skills and resources to be involved in health decision-making about their own health. The second strategy is to strengthen governance and accountability. So really looking at the involvement of service users and families in health policy making at that higher level. The third strategy, which we'll focus on today, was reorienting the model of care. So a stronger focus on primary health care and community-based service models rather than hospital and institutional models of care. The fourth is to coordinate services within and across sectors. So getting different departments within ministries of health to work better together, as well as working with, for example, Ministry of Social Solidarity, Ministry of Education. And the fifth strategy, which is kind of a broad one, is really recognising that without sufficient funding, political will, that broader enabling environment, none of those 4 previous strategies can work. And so this framework is really important because it's the first international framework to define and strategise people-centred healthcare. And while it's not specific to mental health care, it really aligned with the strategies that we see about people-centred mental health care that have come out of high-income countries. But I think most critically for this research, this framework is very important because it was called for implementation in all countries, irrespective of their development status. But given that the paradigm of people-centred mental health care has really emerged from high-income countries, and there's quite a lack of evidence of these strategies in low and middle income countries. So for my PhD, I drew upon interdisciplinary literatures of anthropology, critical disability, as well as global health and health services literatures to identify 3 key divergences between people-centred mental health care and the literature from low and middle income countries. So the first is, who are the people at the centre? Because of that emergence from patient to person-centred care to then people, many of the strategies for people-centred healthcare are actually quite individualistic, emphasising individuals' empowerment and etc. So there's actually a wealth of literature from many decades showing that many low and middle income countries are traditionally sociocentric or collectivist societies, not emphasising so much the individual. The second consideration is really, how is mental health understood and explained? So people-centred mental health care is really based on that biopsychosocial model of mental health. But we know that in many societies, there's actually bring in lots of other explanations, physical, environmental, natural, spiritual explanations and treatments for health and mental health. And the third, which again we'll speak about today, is what type of care is acceptable and feasible? And these are implementation science questions. But really, the people-centred healthcare framework as it's currently formulated focuses primarily on the health sector. But we know that in many low and middle income countries, there's a really strong reliance on traditional, religious, customary healing. So given these theoretical considerations, I conducted a systematic investigation of people-centred mental health care in Timor-Leste. So Timor-Leste is a small lower middle income country in Southeast Asia with a population of 1.3 million people for the whole country. And it's incredibly culturally rich and biodiverse. Mental health is important in Timor because of the known risk factors for mental illness, including the impact of the 25-year conflict, resulting in Timor's independence from Indonesia in 1999, as well as poverty and unemployment being quite high in the country. It's estimated that there's 11.6% prevalence of mental health problems in Timor. So that's the kind of deficit side. The other side would be that Timorese have holistic notions of health and well-being. And because mental distress is primarily seen to be connected to spirits, ancestors and nature, most Timorese people seek care from customary or traditional healers first off for any mental health concerns. The public mental health system, in line with people-centred care, is largely community-based, and mental health is seen to be integrated into primary care. But like many low and middle income countries, human resources for mental health are a big issue. There's 3 mental health care professionals per 100,000 people. These are mostly mental health nurses. There's 1 psychiatrist in the whole of Timor, which, you don't necessarily want 1 psychiatrist per person, but that's quite a big task for 1 person. So Timor is in the process of strengthening its mental health system. And my research really started as a result of my colleagues and supervisors helping to develop the national mental health strategy for Timor-Leste, which was focused around kind of these people-centred approaches. So mental health in primary care settings, relying on intersectoral collaboration. But there was no research to guide implementation of this mental health strategy, and that's where my study fitted in. So doing that kind of conceptual critique of people-centred care, but also wanting to make sure that the findings were doing something. So feeding back, working with and feeding back to the Ministry of Health about how that might inform their strategy. So this is the overarching framework for my PhD, and I'm obviously not going to speak to all of that today, but just recognising that the work today, which is focusing on mental health services, sits within a broader socio-ecological lens that I used to investigate people-centred mental health care across community, service, system levels in Timor. And for me, acceptability and feasibility, I defined really acceptability being the sensitivity of a health intervention or way of providing care to the local socio-cultural dimensions of both its beneficiaries, so consumers, and implementers, the providers. And feasibility really focusing on the resources, practicality and sustainability of people-centred approach to mental health care. So design and methodology, I realise you're probably getting a bit of a lag at this point. So I lived and worked in Timor for 1 year for this data collection for the PhD from September 2017 to August 2018. And I conducted the research across multiple sites. So at the national level, Dili, which is the capital, was selected because it's really the hub for all national government ministries, the National Hospital and the National Mental Health NGO that provides some care. And then I did a kind of case study within Balcao municipality, and within Balcao, its little administrative post, Benelale. And that's because they had kind of representative service provision and socio-demographic profiles compared to the rest of Timor, as well as having an existing research collaboration with my supervisors, which is incredibly important. And La Clua I also visited, which is in Manatuto, and that's because that's the site of the only inpatient psychiatric hospital, which is run by St. John of God, which is a religious charity organisation. So I adopted a mixed methods design for my research, with in-depth interviews as being the main source of data. I conducted in-depth individual or group interviews with 85 people, so aged over 18, from 5 different stakeholder groups. So 20 people with mental health problems, mental illness, 10 family members, 23 service providers or practitioners from the mental health and social sectors, government decision makers from those different ministries, civil society members, and other community members and organisations. And this is really to glean a deeper understanding of their experiences and perspectives of current mental health service provision and testing out some of those people-centred ideas. Interviews were collected directly in English by myself, or were interpreted in Tetum, Portuguese, Makasai and Kairui, which are the local languages of Benelale, or some of the local languages, I should say, of Benelale and Balcao. And so I did about 56 hours worth of interviews. And I also did some informal observation in health and social services in Benelale and Dili. And so this really involved me following shadowing the health staff around as they did their outreach services, hanging out in the clinic in Benelale, as well as participating in some of the NGO provided client work. And so that was about 500 hours. I did the data analysis for this work using framework analysis, which are deductive and inductive. So having those kind of deductive a priori themes based on the WHO framework of people-centered care, but also inductive or emergent themes coming out that I hadn't predicted before and that were really capturing some of that richness. I also did, after I'd done some of my preliminary analysis, I did 9 different presentations back to the community and different stakeholders as a means to kind of feedback, because often I think researchers come and go and people don't know what was concluded or might not agree with it, but also as a way of validating, so making sure that I had understood and captured the essence of what people were saying. So I presented, by that point I could speak Tetin well enough, so I presented back to the Venalale community, to about 50 chiefs about the results from their area, as well as different stakeholders at the kind of national level and of course Ministry of Health. I include this next slide, which is around the realities of data collection in Timor, because I think often we can present things in a way that looks very linear and clean, but that was absolutely not the case for this work. So I think one of the key challenges or differences between doing work in Timor and in Australia is really different concepts of privacy and confidentiality. So because of the family-centered approach to care that we'll talk about in a minute, it was not uncommon for people to kind of come and go, family members to eagerly sit on the edge of our informal chats as I did interviews. And I guess the important part was that the Timorese people didn't see this as being an issue. That was just kind of how life worked. Permissions and snack packs. So again, because of the hierarchy I'll speak about in a minute, there's quite a lot of permission that needs to be sought across lots of different levels of government, for example, for doing this work. And so the top right-hand picture is, you can't see it in its entirety, but it's a picture of 24 different snack packs, which were goodies for the ethics committee to eat while I presented. So I applied in paper for the ethics application, but also then had to do a presentation and answer questions, which was actually really great for getting their views on the research. Transport is a huge issue in Timor, not just for conducting research. So you can see down the bottom, there's the image of the bus and me and my friend on the bus. It was with the face mask because of the level of dust that comes into the bus. So 15 hours sometimes to get from Dili to Venalale on the bus at that point because of the construction that was happening. I guess my researcher position. So again, this is primarily qualitative research we're talking about, and recognizing that I come to this research and people-centered mental health care from both a professional and a personal perspective. So I'm officially trained in psychology and public health. It's my kind of professional hat. But also personally, I've got family members with mental health problems that have happened for many years. And so I think that really can bring depth, but also is something that I'm aware of and reflecting on in terms of why I'm interested in involving consumers and families in their care decisions. Language is also important. Obviously, I speak English as my primary language. I did learn Tetin while I was in Timor, and that absolutely helped things, but I still used interpreters even despite having sufficient Tetin to follow and talk, just to make sure that the data was valid and I was actually understanding properly. And being an Australian in Timor was an interesting time, or just generally. So for those who don't know, there's kind of disputes and ongoing disputes between Australia and Timor about the line in the sea of where separating Australia and Timor, where the oil reserves are, and some dodgy dealings that happened in the past that mean Australia really get the better end of that deal. But while I was there, it was quite strange to see a big billboard of Julie Bishop, who was the then foreign minister, putting an end to the shadow of the past and the relationships between Timor and Australia. But I guess what I would also say is that's kind of at the higher level, and really at the local level, at the person-to-person level in the community. There's been many great relationships between Australians and Timorese for a long time. So the oil is a point of contention, but really came up on that personal level as just a bit of a joke and a dig at me as an Aussie. So what did I find in terms of the acceptability and feasibility of mental health services? So really, the key finding was this family-centered ecology of mental health and mental health care in Timor. So this idea that you're not just approaching the person with mental illness, but you're approaching and need the approval of their family. So families' roles in relation to the person with mental health problems were to take care of the person, were seen to be making decisions about when and from where they would access support, and accompanying them to the health service or the traditional healer. Families themselves asked for more support and more information about what mental health was, what mental health care was available, and their priorities were informed by the broader development context. So they also just talked about needing things to meet their basic needs, so food, clothing for their loved ones. So there was that family-centered or sociocentric conceptualization of what it is to be a person or personhood. But recognizing as well that people with mental health problems were seen to have altered capabilities and societal roles and really had this diminished personhood. So they were seen to not be capable of making rational decisions, not trusted with socially significant tasks. They reported bullying, physical and sexual violence, and some people reported being or were confined to their homes. And I'll talk more about why this might happen in a minute. The power hierarchies in the health setting were quite different to the empowered individual or group of consumers that we see in people-centered mental health care. So Timorese people made decisions in reference to their family's needs and with respect to their position in the socio-cultural hierarchy of big Imabot and small Imakik people. So as members of a marginalised category of small people, Timorese people with mental illness were generally not deemed to be responsible for making decisions about their health or other things, but also that the idea of their participation in making decisions with the doctor at that individual level, as well as the health service level and policy making, was quite novel and people found quite strange. So Timorese people went to the doctor and they expected that the doctor would make decisions about their care. And this really makes sense because if you think about by the time the Timorese family are going to the public health service for mental health care, it's often when they've already seen traditional, customary religious healers and that's not worked. So they're actually going to the health service to be told what to do. That's the main motivation. Despite the benefits of having that family-centered approach and the real protective factors of that, there were instances when individual and family needs and rights clashed. So some family members said that they employed chains or shackles to ensure that their unwell relative didn't run away. And this was really an extreme example of a motivation to protect their unwell family member. It's important to understand that many family members didn't want to do this. This happened when families didn't know what else they could do, when they didn't have any access to other supports. And it's really an example of that clash between the individual and family needs and their sociocultural power hierarchies. But also showing, as this quote shows, that it's not necessarily the people in the family that are making decisions that you might think. So this service provider talked about how a man had come to his clinic who was chained. He'd said, I would like you to unchain this person for me to treat them. The family deliberated about this decision and it was the powerful uncle rather than the father of the family who said, no, we decide not to. Participants reported using plural forms of support for mental distress, which was in line with different explanatory models of mental health. So seeking traditional healers, people going to the government mental health care, which they mainly did through house visits or through the mobile health clinic. And the focus of this was really on providing medication or getting medication. Some people access psychosocial rehabilitation, which does emphasise more consumer rights, from that NGO Pradet in Dili, but this wasn't really accessible to many people outside of Dili. A key unexpected finding was the demand expressed for biomedical treatment. So when asked what was lacking from the current mental health system, the vast majority of people, including people with mental health problems and their families, asked for a hospital. We need a place. And this is a picture of the St. John of God Institute or institution in Lakluba. So I think this demand for a hospital could reflect multiple things. So it might reflect a preference for what works. So this intersectionality of the feasibility issues, families juggling priorities, as well as the potential for an institution, a retreat in this case is what Clubar is like, providing respite from negative community experiences for many people with mental health problems. This demand for biomed can also reflect expectations of the public mental health system. So it might be that many Timorese people don't expect the public mental health system to provide broader aspects of care, as people-centred care kind of advocates, because these are currently addressed by families, tradition and culture. And so the hospital is really seen to be the best type of health service available. And it could also reflect this broader request for more personal and family support. But I think this is a really important finding because it emphasises or raises the question about how does this people-centred framework accommodate when there are different care preferences expressed to what those are in the model of care. So model of care is promoting community-based care, and in this case we've got a big demand for biomedical hospital-based care. Feasibility challenges I won't rabbit on about too much. They're in some ways quite predictable. They're barriers at individual service provider and health system levels that you see in many low and middle income countries, particularly in the area of mental health. So families and service providers wanting more information or knowledge about what was available, what mental health could be conceived to be. Transport issues that we've spoken about. This picture on the top right is really a healthcare provider walking with a esky of vaccinations during wet season, rainy season, when the road had washed away. Staff capacity, training and support. So many staff who are working in the mental health area get kind of maximum of 2 weeks official training in mental health before they go out, often alone in a relatively stigmatized, part of healthcare. Medication supply, which is important. This bottom picture shows the available medication for all types of conditions for Venilale for 3 months. And so there's a huge challenge with getting a regular access to medication, which if you think about that being the primary role or source of treatment for mental illness is an issue. And then health systems information, so everything's still paper-based. There's not great ways of tracking across different providers. So in summary, we've got this family-centred ecology of mental health and mental health care. There are plural and different preferences for types of mental health care in Timor that differ from the ones that are proposed by the WHO and people-centred mental health framework or people-centred health services framework. Decision-making in the health setting was different from that kind of empowered individual or group of consumers, as we spoke about, and the challenges to really, the basic services in Timor were not being provided to everyone's desired level. So the idea that you would have this kind of additional social, more psychosocial approach to mental health was really challenged by feasibility. What does this all mean? So implications, I think, are obviously important at both that practical practice level as well as the conceptual level. So implications for practice in Timor, which we've been working with the Ministry of Health to talk through, are really this need to increase population mental health awareness, but not just from the kind of, oh, this is what mental health means in the West, but really incorporating those sociocultural understandings of mental distress, not positioning traditional explanations and explanatory models of mental illness as kind of inferior or backward, which often is the case when we do this work in low and middle income countries. That real need to adopt a family-centred approach to mental health care, as well as stigma reduction and social inclusion. So I didn't touch on this today, but the impact of having a family member with mental health problems was felt by that family member as well as that family. Really, despite the fact that it was strange that you would have people with mental illness involved in direct decisions, the work that had been done by the NGO and in the social sector, and particularly the disability sectors, had been bringing in more people with psychosocial disability and other types of disability. And there had been a big strength, particularly from a stigma reduction perspective from that. Other sectors, you're not going to do any of this work just in the health sector. So linked to that idea of participation for people with mental health problems is supporting emerging networks of people in civil society and that broader enabling environment of ratifying the United Nations Convention on the Rights of Persons with Disability to ensure that human rights are protected. Implications for conceptual development. So I think we've touched on all of these, but really recognising that the people at the centre of mental health care is not an individual as a first primary point and as a family as secondary, but in Timor they're really intimately connected. The need for this concept to recognise different explanatory models of care, so spiritual, ancestral and natural explanatory models of care, and to accommodate different or to address different sociocultural power hierarchies, the health access barriers that exist in many countries, including Timor, and recognising that many of the supports and primary pieces of work, particularly around if you're thinking about provision of basic services like food and clothing, aren't coming from the health sector, they're really coming from the social sector and human rights. So bringing those disciplines and sectors along in this journey. Just like to come to the end, just like to thank all of the participants for sharing their experiences and time with me, my supervisors who you'll see all listed there, and different funding that I received to kind of get this work off the ground. Any food for thought questions? I'm really looking forward to hearing from you now. Thanks.
Thanks for that, Tess. That was fantastic. We already have a comment in the chat box, and it's from Becca Alchin. She says, interestingly relevant in Victoria with the Royal Commission on Mental Health to consider the same 3 questions in people-centred approach. Who are the people at the centre? How mental health is understood? And what care is acceptable?
Absolutely, Becca. I think that's really important. And in some other work that I've been doing in Australia, it's this idea, particularly with Aboriginal and Torres Strait Islander communities and social and emotional well-being. It's often this idea of, holistic work needs to be done in diverse communities and culturally, linguistically diverse communities and First Nations communities. But actually in the mainstream community, there's a whole lot of strength and support for and use of these different approaches to care, not healthcare, not necessarily in a service system, but actually based in the community and supports there.
Yeah. So Tess, I was very interested. You said that you were there in 2018, was it?
2017 to 2018, and then returned again in 2019. Yeah.
And have you noticed, given the strategy, that national strategy, have you noticed any changes over time?
So I think pre-COVID is probably a different story. Unfortunately, there was kind of political dispute between the different leaders at the time that I was there, and that continued until 2019. So by the time I returned in 2019, in some ways the situation was actually worse. Mm-hmm. So there was even fewer resources for the broader health system because the budgets were frozen. Because at that high level they couldn't get their official budget passed, they just kind of continued on the budget as it had been. The other kind of change that had happened is Pradet, which I didn't really shine a light on them as much as I should have today, but they are the NGO provider that do all the psychosocial rehabilitation, but they do much more than that. They have taken an incredibly family-centered approach. They often are providing food and clothing, etc. And they had been based, there'd been a kind of long-term tension between Pradet and the National Hospital around where Pradet was based. So Pradet were based in the hospital grounds. And by 2019, they were actually formally evicted from the grounds. It had been about a 20-year conversation on and off. So Pradet didn't actually have an official service location when I returned in 2019. And we're doing outreach kind of from the car, just driving around to where they knew that many people with mental health problems lived, or in the Dili setting where many people who were homeless with mental health problems were, to try and give them some basic supports. That's pre-COVID. Post-COVID, or in the COVID world we live in now, because mental health is now, or psychosocial supports in this kind of disaster space is now on the agenda, despite the fact that the kind of longer term mental health system work in Timor is not necessarily improving, they have actually had quite a few really innovative approaches. So there's now a national mental health hotline that people can ring in. There's there were text messages sent out by its various telecom providers to kind of remind people to check in their mental health. These are some of the things you should look out for. So I think there's a lot of opportunities, but again, it's that long-term investment is really difficult and from a Ministries of Health perspective, that's because there's so many different areas, so many different priorities. And when you're dealing with the burden of disease from infectious disease at the same time as this longer term chronic illnesses like mental health problems, they do fall to the wayside.
Yeah, certainly. So we don't have any more questions yet, so I'll take the host advantage and just, if you can talk some more about that stigma. It's a really interesting one, you know, that there's certainly a stigma associated in Timor-Leste, but, you know, we appreciate in Australia that stigma that's associated with mental health. Any similarities or differences and ways of addressing it that you can comment on?
Yeah, I mean, I think you're absolutely right. And in some ways, there's a lot more protective factors in Timor because there's not, well, the things that the Timorese found incredibly shameful were homelessness. For them, that was the absolute sign of the family abandoning their loved one, that they'd let that person down or had gotten to the point where it's just so extreme. And so that's for them. And I think it's very difficult for us to understand, well, I guess chaining and restraint happen in different settings in Australia. But the restraint and confinement of their family member to the house was seen as the better alternative than to abandoning the person on the streets. A lot of the stigma in Timor was driven by a very narrow version of what it is to have a mental illness problem, or a mental health problem, I should say. So really that kind of more pointy end, untreated psychosis that could be associated, not always, I don't want to perpetuate that stereotype, but in that context was seen to be aggressive, dangerousness, people at risk, or events had happened in the community. So I think that was also the challenge, is when people were thinking about mental health problems, they were often thinking about very extreme behaviour that didn't capture a whole spectrum. I think in Australia, there's obviously been a lot of work to change this perception, still a lot to be done. But that normalization of, you know, people struggling at different stages of their lives and more of a continuum of mental health. So, you know, struggling and coping rather than symptom-based.
Yeah, yeah. Okay, so still no additional questions. So if
I think we've got one in the question and answer.
Oh, thank you. So Carol says, thanks for your brilliant presentation. I think this research is a significant contribution to not only mental health approaches in lower income countries, but also health approaches in multicultural higher income countries, where issues of economic disparity is common alongside the many other social determinants of health. How significant an impact do you think this research will have in countries where their politicians' interests are other than the people themselves?
Oh, big question, Carol. Thank you. I think that there's a reason that we've been pushing to get mental health recognised as a key social determinant, or we've expanded health to well-being, health and well-being, and trying to incorporate mental health there, because I think that it's still seen as something that's really difficult to do. As the movements and recognition that all health requires multifaceted intersectoral approaches get stronger, then I guess the hope would be that, because that's what is required for mental health in particular, the hope there would be there would just be a kind of a pathway or a normalization of that need for holistic care. Because I think at the moment, in many cases, there's this idea that it's easier to treat particular types of physical health issues. So let's just do that. That's a very clear evidence-based intervention. And when you're trying to get a complex intervention or a complex set of responses evaluated and implemented, it's more time resourceful, really. I don't know if that answers your question.
Okay. So no follow-up question there. So hopefully you did there, Tess.
Thanks, Carol.
So if there's no more questions coming in, wait there, just got, yes, thanks very much from Carol. I'd just like to thank you again very much for your presentation, Tess. It was really good, and I certainly wish you all the best. We'll just leave it there. Thank you very much. Just a reminder that the recording of this session will be up on the website in a few days. Sometimes Sarah does get it up on the website on the same day, but certainly if it's not today, have a look next week and share that around.
Excellent. Thanks very much for having me. Thanks, Tilly. Thanks, Sarah. Thanks
everybody. Yeah. Thanks, Tess.
Thank you.
Bye, Tilly.
Bye.